Remember, front desk is a piece of furniture and girls at the front desk a brothel. So the ladies in the business office, what you're doing is you're transferring the expertise of the conversation to be in the place where it best belongs. Because who's not going to be presenting fees? The clinicians. Now, some of you, that makes you like get an ulcer, but I'm not saying you can't do it. I've seen clinicians be very good at presenting fees, but it just devalues you on what you're doing in your diagnosis and treatment planning versus the ladies in the business office. That's what they do all the time.
So the business office is not a separate office?
Okay, that's called a consult room. Okay. So if you hear me say consult room, okay, so the business office is the 3 to 5 minute checkout, okay, where we escort the patient to be transferred for their checkout, or consult rooms where they go to sit knee to knee for larger, longer explanations. Okay, thank you for the clarity.
Hope he's not from an insurance company trying to figure out what we are figuring out.
I love spies because we don't really do anything wrong. We just try to be great, right? We're not unethical. I'm not saying invent, push harder or, create things to do. There's enough to do in dentistry in this country, right? We don't have to. Another question? Sorry, I see a hand over here. Oh, over here.
So let's say if someone comes in for a specific exam, national specific,
right?
They broke a tooth, then they're not going to the business office before they do the treatment. When do we present treatment?
Oh, great question. Okay, so the question was, let's say you're doing an urgent specific exam in real time, but you can't say hi. Go to the business office and come back. Okay, they're going to think you put something in your cornflakes, okay? So you can have someone from the leave the clinical room, have someone that dresses normally from the business office come and sit with them chairside. Right, like an emergency. Do I have a root canal? Do I pull it? Right? You're going to get into those conversations. The key is, why is this? This isn't Lisa Philpin, Transitions, and Lori and Mel and Chris's opinion. It's how people make decisions, and we're training them to make the part of their decision the best they can in the right context. That's really what this is, okay? And when they say how much, clinicians, don't say, I don't know. They saw your BMW. And they know where you live. They have crap detectors. They'll say, oh, I don't know. They don't tell me fees here. Okay? They're going to know better. What do I say? How much is it? Great question. Great question. The ladies in the business office will go through your total investment in flexible ways to fit it into your life.
So not even the assistant should say anything? Like I can leave the room and have the assistant?
You know what? It's hard. Remember, there's not just one absolute. I'm giving you what? I'm giving you the ideal so you can filter it back to your uniqueness, right? So is the world sky going to fall if the assistant can do a presentation? Most of them are happy not to. Because they're so busy when you leave the room going, do you know what she said? Right? Literally, ask your dental assistant, what's the first question patients ask when I leave you alone with them? And that's a great thing to know. It's not because patients aren't nice. When there's something about how they make decisions with the great one there.
They just hold their head.
Right? Remember I said dentistry is a team sport. Why? Because if a dental team doesn't believe in the dentistry and the providers, they will make or break patient loyalty, retention, and acceptance, right? Because the patients, what are some questions your patients ask you as a non-clinician? What's the most common question? What do you think I should do?
Is it important?
What do you think I should do? If I look at them and go, I don't think you should do anything, it's way too much money here. It's a career-ending move, just saying, right? Or I say, ask it again.
What should I do? How much is it? How much?
Our role is to support you to do the best. And the results of your exam show this is the best for you. What's the other one they ask you? Would you do it if you were me? They're looking to the team for advocacy. I tell doctors all the time, you can eat craft dinner or steak. It depends the energy you bring in, and not how nice you are, but how the energy you bring into the team, because they're all a reflection of who? The leader. If I come in a really irritable mood, and someone calls and says, so how's Lisa today? She's a witch. It's going to be the tone, not the word. It's going to be the tone, not the word. So when you are, what we're doing is saying, putting the relevant conversation, remember, what is it about? How do we be efficient and productive to be fulfilled in the workplace, to have a better future than our past, serving patients in their gums or teeth or jaw joint and their smile? Did I just simplify our entire profession? Yes. But that's the mindsets that are created to do that. It's not that you can't talk money. There's no can't. It's best. And remember, this is not our first year or first time teaching. Thousands of practices that do this. We have to take the best from the majority. Then you bring your uniqueness into it, right? So the really ideal rule of thumb as a consult room is anything over $1,000 goes to a separate glass room with knee-to-knee communication so that I can talk to them in lay terms. That drove dentistry to where it is today at $13 billion. Because people will make a better decision sitting with you, being safe, than they will being dumped at a 3 to 5 minute bus line with their visa being declined with all their neighbors behind them.
I had a question, back to the diagnostics metric.
Yeah.
You said something about measuring how many exams you do in a year, right?
In total.
Yeah, and then relating that to what it generates in treatment plan dollars.
Yeah.
How do you make that jump? The correlation between both?
Okay, so the diagnostic, you take the number of diagnostic exams. That tells you how many touch points did you have as a dentist to look at conditions, to diagnose solutions. Okay, so really it's the correlation is the tripod. Okay, so the tripod is the diagnostic exams. What's still in the charts? That's your outstanding dentistry. Okay, that's going to be harder to find, and we even have to do a full day chart audit to find that out. That's the one thing you just can't get that's accurate. Okay, but then you look at what's your treatment plan. So if you scroll down to see down here under case acceptance, cases planned and presented, that's your correlation that you can manage. I'm giving you to get a history so you have a benchmark. Then when you start tracking how much major dentistry was planned and presented, you correlate that back to how many exams did it take to get that. Make sense? Because think of the four moments of truth in everything we do in dentistry. You diagnose the condition, you plan the best outcome, you present it, you make it affordable. It's a 4-step, boom, 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 boom. I'm simplifying it because it's really not that complicated. You diagnose it, hygiene status, what's going on. Diagnosis is the conditions inside their mouth. The treatment plan is procedures to treat those conditions. When patients get this simplicity, they tend to understand it better. You diagnose it, you plan it, you present it, you make it affordable. Then where does it go? In the schedule. Diagnose it, plan it, present it, make it affordable. So your diagnostic exams are how many opportunities did you have to treatment plan any type of dentistry? And I say just track your major. Because your computer can tell you your drill and fill, your MOs, your continuing care, right? It's more the larger value dentistry, what we call ROCs or primary appointments. Question?
Question about is it covered? So if I'm telling the patient that your insurance doesn't share this information with me and I'm your patient, my first thought is, oh crap, am I going to have to sit on the phone with my insurer to try and figure out if this technical procedure is covered or not. So how do you make the transition? If I'm understanding you correctly, you're trying to get them to buy into the procedure first and then guide them over to the business office where they will help them navigate the insurance?
They won't speak for the policy, but think of it, yes. So that's the inevitable goal. But here's the thing. What's the reason? remember, go back to the why. Whenever you're questioning something, you go back to why are we doing this? It's because the patient needs to get, they're the policyholder. We're the provider. The employer does this and the insurance company does this, okay? But yes, transferring them to the business office to be able to sit down and support them in maximizing their benefits is what they can do. And you don't use chair time. Chair time's valuable, right? Chair time is extremely valuable to do non-efficient, non-relevant things in that area, if you thought of it that way. So yes, so the goal is, now if they said, oh, well, I don't know what my policy is, I don't know what I have benefits for, you have nowhere to go but up. Because they need to take some responsibility, and I tell them, I'll work with you and support you here, but just so you know, they often won't talk to me because I'm not the policy holder, right? Sometimes you might get on the phone. New patients at the end, not the beginning of the call, you say, if you have any support or financial assistance for your dentistry, please bring your policy with you or your booklet or call your HR department. New patients, you can get them to bring it with them. Okay, it's unraveling a training that's causing us a block to retrain ourselves. And it's not that we're going, I don't do insurance. Okay. That'll be a good way to have attrition.